during early COVID, we had a decision to make. We needed to decide, do we cut our costs and let go of a ton of workforce, which itself is often on the cusp of poverty? Or do we take the short or medium term hit, invest more in the company, keep people on board as long as possible, with the bet being that if we keep them on board, we're going to have profoundly more employee loyalty, profoundly better customer experience, clinical quality, and we'll be the fastest ones to ramp back up once all the stay-at-home orders get pulled back.
Welcome to Startup Health Now, the podcast where we talk with the entrepreneurs shaping the future of health and discuss the health moonshots that they're working to achieve. I'm your host, Logan Plaster. Today on the show, we've got an esteemed guest, Dr. Andrey Ostrovsky. Andrey is many, many things. He's a practicing doctor, a pediatrician, and an entrepreneur. In fact, he founded and sold a company that was part of Startup Health's portfolio many years ago. In 2016, Andrey took on the role of Chief Medical Officer at Medicaid. Then he rolled all that experience up and became a health innovation investor. Andrey's done it all and is generous with that experience, so it was great to have him on a recent Fireside Chat with a few dozen founders from the Startup Health portfolio. If you enjoy conversations like this about the innovative thinking necessary to improve health around the world, make sure you're subscribing to the podcast and check out our Health Moonshot Update series on YouTube. Now, here's Dr. Andrey Ostrovsky. Well, let's start a bit with your journey. I mentioned that you are a health transformer, founder of a company called Care at Hand. And so could we go back and tell us what your company was all about, what you were building when you were a founder in the Startup Health family and in the portfolio, kind of what that was all about?
Sure. Care at Hand was going after the problem of helping people age and thrive in the community safely. My co-founder and I, Jeff Levy, we had the insight that there was some really productive mobile technology developments around 2010 that could be applicable to the home setting. And increasingly, there was a financial incentive and push to keep the elderly out of the hospital, preventing readmissions. And we thought technology could really support that process. So we created a platform that identified which elderly individuals could be at increased risk for hospitalization, and in particular, rehospitalization. And the unique aspect of our approach was that we had the insight that the most influential care team members were not folks like me as the clinician, but usually the non-clinical care team members. And so we thought if there was a way that we could somehow digitize the hunch of a non-clinical care team member, like an adult child or a home care worker, perhaps that could be a way that we could use the existing people around the patient to identify risk factors for readmission, and then have a leading indicator that care teams could use to intervene and prevent someone from bouncing back to the hospital. We ended up developing some pretty elegant technology, publishing some studies around the validity of those algorithms and that technology. And then we ended up selling the company to a company called Mindula Health in 2016, which to this day is using the technology we built as the backbone of their platform. So that sounds like a great, fun journey and success and all that, but I'm happy to tell the more important parts, which are huge missteps.
Yeah, exactly. Totally. Let's dig in there. Well, what do you wish that you knew then that you know now? What do you wish that 2013 founder knew?
I think one of the key tenets around investing and or operating in the digital health space that I think I ended up discovering around, I think it was 2013 or 2014. So 2010, 2011 is when we founded the company, and we were going after a pure software play. And it became quite apparent then in 2014, and I would say it's even more so now, that creating value outside of the healthcare space is totally possible with the pure software play, especially places like fintech or prop tech, or insert any other space in tech. Healthcare, however, I found that if a solution or an experience does not own the substantive chunk of the healthcare stack, that it will never break through or overcome the activation energy needed to create enough value in the healthcare system, which is a mostly fee-for-service system. And so what I've kind of relegated in my mind, pure software plays in the digital health space, is really only in kind of business processes, or maybe business process as a service. So revenue cycle management, I have a couple of investments in that space. I think those companies will do really well, and they're pure software plays. On the front end of healthcare, care coordination, care management, risk prediction, population health management, I think it's incredibly hard to build a viable venture level growth business that's pure software. And so in probably 14, what I should have done is actually closed down the business and then rebooted it as a full stack offering of tech-enabled services. And I'm very bullish on tech-enabled services, and that's the majority of my portfolio of investments. Out of, I think, 18 investments now, most of them are tech-enabled service businesses doing very boring things, which is going after fee-for-service, basically tackling boring brick-and-mortar businesses and just out-competing them because the technology happens to eliminate certain inefficiencies and or create a more convenient patient or consumer experience. That's probably the biggest thing I should have done to create investor value and more importantly, patient value. But I was a stubborn first-time entrepreneur who was also in clinical training, and I thought I knew what was best. And yeah.
What were some of the lessons you learned going through the acquisition process?
Don't start a company. No, I'm kidding. I'm so grateful I did it. I would do it again. I found that having a few dozen angel investors was a very painful experience to get signatures. I found that having clear communications with investors was probably one of the best pieces of advice I took, which I know like Unity reinforced, and Steve was probably one of the first people that really drilled it into my head how important good investor communications is. Because when you get a pivot, we went through three, I don't know if Unity, you remember this, but we went through 3 acquisition offers between January of 2016 and when we sold the company in May of 2016. And 2 out of the 3 acquisition offers had very significant, let's say, interactions with investors that weighed on the outcome of the acquisition or the negotiations. And I've advocated for many of my portfolio companies now to be really careful about whose money they're taking and trying to minimize taking, the usual, like you set a limit on what size check you're willing to take. And if it's a small check, it damn well better be a very strategic investor. And also one that's really mission aligned. Nothing against private equity folks. I'm on a couple of boards owned by private equity companies that I deeply respect. But I have to say, like, the biggest challenge I had in navigating the M&A activity was from a couple of angels who were private equity folks that had a private equity mindset and clearly never operated a startup. And so expectations were fundamentally different. They were talking about, well, what about my warrants and exercising certain options? I'm like, this isn't PillPack, my friend. Like this is a much more modest. This is a much more modest transaction, and you're compromising some kind of interesting investor returns just to kind of be, frankly, greedy. So I can't really generalize to private equity folks, but just being aware of angel investors, backgrounds, mission alignment with the company. And I recognize saying that is really easy to say now that like I'm out of the pit. I know like getting any money in is so valuable, and like we can't be particularly picky, especially early on in fundraising. But where it is possible, sniffing out for lack of a better phrase, the douchebags early, it can really help out in the M&A activity. And I will say, like, I just sold a company on December 31st, which I'm super excited about. And, with a little internet sleuthing, you could probably figure out which company it is. And we'll have some like PR coming out in the next couple of months from the acquiring company. I took those lessons, and I was on the board of that company. I took those lessons to heart and very significantly protected the founder from other investors who are basically trying to pull the same bullshit, and reminded them that, that whether you get an X percent of the transaction or X plus 1% kind of doesn't matter, because this isn't $1 billion transaction. And so I think having an entrepreneur mindset and a founder-friendly mindset is really what I learned from my M&A activity, and I think that's been good, because I have a generally a favorable reputation with my companies that I usually go to bat for my founders, regardless of my financial returns.
Nice, that's awesome. Let's fast forward a little bit in your journey. You were asked to be the chief medical officer at the Office of Medicaid. And I just want to stop there and just say, what was it like to get that offer, that phone call? If you could take us back to kind of that transition period, and just what was that like?
I think it was a testament to the whole notion of, Pasteur, whoever was quoted as saying, luck shines favorably on the prepared mind. I was very lucky to have an opportunity to take on a role for which I was grossly unprepared for, and simultaneously way overqualified for. And what I mean by that is, I had sold into Medicaid pretty extensively as a pediatrician. Most of the kids I saw were Medicaid reimbursed. I understood, many of the peripheral aspects of the Medicaid program, but the guts of it, the policy, the statutory, the regulatory underpinnings, I really had no idea. And so in that regard, I had a lot of angst around taking on a role that, I wasn't a lawyer. I didn't understand some of those aspects. But what I was being asked to do was introduce change management to a highly bureaucratic organization. And as a startup founder and someone who it took some level of rigor in building my own skill set around, building product, customer development, strategy, general organizational management principles, and design, agile, lean, those types of skill sets. That's basically the toolbox of change management. And I knew those things pretty well. And that's what I was being asked to do, to come into the National Medicaid program and help evolve the organization to be more customer-centric and more streamlined. The way I got that role was one of my mentors, Patrick Conway, who remains a great mentor and friend of mine. He's someone who I had a quarterly mentorship call with ever since I started residency, and I had given him, we had our regular check-in. I think it was mid-May of 2016, and I said to him, like, "Hey Patrick, I think this is actually happening. I think we're actually selling the company, and I have a year-long earn-out period, but after that, I'm kind of free. And if there's any big problem that you think I could be helpful with, let me know." And he ended up reaching back out to me in a couple of weeks saying, "I've got a job for you, and I need you to go help run this program." And to which I responded, like, how the hell could I do that? Like, just for the same rationale I just laid out to you all. And he reminded me, and it was very obvious, like it was an opportunity of a lifetime, and that, if you can figure out starting a company and growing a company and selling a company like you all are doing right now, you can pretty much figure out anything, right? Like our jobs are literally to learn super fast, be kind and gracious, and discover value super efficiently. And the whole, walk through walls metaphorically, in some cases, literally. That was a pretty good preparation, and so I took the role, and it was the first 4 months were awesome, and then they weren't. But I'm grateful for the experience. It was a great learning experience.
Why don't you take a moment to kind of school us a bit on Medicaid and Medicare? You said you came in having sold into Medicaid, but then really didn't, there was just a body of information that you didn't know yet. So I'm sure it was drinking from the fire hose of information. We've got folks on the call who some play in that sandbox, some don't, some from the United States, some not from the United States. So Medicaid versus Medicare, give us some top line knowledge.
Absolutely. So Medicaid is the national public health insurance program for people who are in poverty and or who have some kind of functional deficit. Contrast that with the Medicare program, which is the national public insurance program for people that are 65 years and older, or people with end-stage renal disease, or people also with functional compromise and that have basically been Medicaid eligible for 2 or more years, and they can kind of bump up to Medicare eligibility that way. The statutory underpinnings for the Medicaid program are outlined in the Social Security Act Title 19, and there's a lovely chapter that I do not encourage you guys to go out and read. And then similarly for the Medicare program, it's indoctrinated in Title 18 of the Social Security Act. A really important business development aspect that is a difference between the two programs is Medicare is centralized. It is run out of the Baltimore office of the Centers for Medicare and Medicaid Services. And what happens centrally is basically doctrine across all of the United States, with a little nuance in that Medicare administrative contractors, MACs or MACs, have some local coverage determination flexibility. But basically, if there is a certain CPT code that has a certain level of reimbursement and it's decided upon by Medicare centrally, it basically is gospel across all of the United States. Contrast that with the Medicaid program. It's a federated program, which is a federal and state partnership. Each state and territory, so 56 in total, have their own state Medicaid office. They have their own state Medicaid plan. And each state and territory basically have to get the approval of the Fed centrally in order to approve what is the benefit for whom, how much it's paid out. And so it's highly variable. Medicare, consistent, centralized; Medicaid, highly variable and state-driven. And that creates a pretty interesting challenge or opportunity, depending how you look at it, when we're thinking about getting our solutions reimbursed. Do you want to go for spend a whole lot of resources, an enormous amount of lead time to get one big bang reimbursement opportunity through Medicare, or to get shut down and basically to never get approved again? Or do you want to have 56 at-bats, which basically take the same amount of time as it does for Medicare? But if you screw up in one state, you go to another. You have 55 other opportunities. Again, oversimplifying, but that's kind of how I would think about it. And then there's also the duals, Medicare and Medicaid, both eligible, which currently stated numbers suggest that 13 million is probably underestimated, more like 15, 16 million. But these are the folks where, we're not talking a $300-400 per member per month premium in Medicaid, or a whatever the most recent data, $956 per member per month average premium in Medicare Advantage. We're talking like $3,000 a month premium. Enormous amount of money that's being spent, and potentially savings opportunity, value creation opportunities. And we can, my team of mentees actually did a research study on duals and technology, which I'm happy to dig in on. But that I'll pause there as kind of a general overview of the distinctions between the two.
So you said that there's pros and cons to going the centralized Medicare route versus the 56 at bats. Do you feel like those are, I mean, you're talking to a bunch of entrepreneurs here. Do you feel like those are pretty even odds, or do you have, recommendations as to how someone should go about this?
Yeah, I have a relatively straightforward recommendation. I would say that focusing your company's business development, customer development, or product development activities should really start with first principles, which is what does your end user need or want? Like, do you want to create value for someone who more likely is a Medicaid eligible beneficiary, or do you want to primarily create value for someone who's a Medicare Benny? Or I would actually advocate in almost all cases, don't start with public payer and go to where it's the easiest to sell when there's the highest margins, which is in the employer sponsored insurance space. And that's a philosophical tune that I have fundamentally changed from the time when I was operating Carrot Hand until now, because I was myopically and ideologically convincing myself that if I'm not trying to serve the duals population, then I'm not doing my job to have social impact, blah, blah, blah. When in reality, like, I wasn't doing my job to have social impact because I wasn't creating a profitable business. And in the end, like, yeah, we had like a fine M&A activity, but it wasn't at the level of scale that anyone would say like has fundamentally changed the American healthcare system. And so I would say build a viable business first, ideally one that is profitable. And if it's not profitable, at least have really meaningful revenue growth. And once you have your beachhead identified and you have that flywheel and you're generating revenue, every customer in the space reflexively thinks of your company's name, then start to evolve your strategic framework for the next 2, 3, 5, 10 years to back into the public payer space. Because then you'll have the margins, you have the credibility with your board and your investors to start taking risks where perhaps margins on a unit economic basis, or not perhaps, they will be lower on a unit economic basis, especially Medicaid, but damn, the TAM is huge. But it's hard to say to investors or a board, or frankly to any smart early hire, oh, we're starting off with Medicaid, with a few rare exceptions. There are some businesses, Cityblock is one of our shared investments, I think, has been able to do it, and there's a few others. But in most cases, I think starting with Medicaid is not prudent. Medicare Advantage, a little different, margins are much more generous, et cetera. But I'm happy to elaborate on that theme.
As a leader, and you're sitting on boards, you're advising companies, how do you help people pragmatically to walk that line between their passion to fight disparities in health, to have that why, and to also be profit driven and to build a business that is going to thrive in a capital market? Because you know that the one feeds the other and you can't have the impact without the success. So as a leader, how do you instill that in people? Because it's one thing to say it, it's another thing to do it.
Yeah, I think if I'm through and through capitalist. I think if people don't see the return on equity investment opportunity in serving poor populations, then trying to convince them that there's some kind of social mission is a lost cause. I very much prefer to lean with show people the green as opposed to show them, the equity impact. And I very strongly believe, and I have some at least process measures to suggest that investors can make comparable, if not outsized returns, investing in populations whose remedying their challenges can drive really meaningful profit growth and multiples on company valuations. So I never try to convince people that, hey, let's do social entrepreneurship and let's have societal impact. What I often do is when there's this is mostly with private equity owned businesses. If there are investors that saw a investment opportunity in serving a Medicaid or duals population, and they have a decision to make a fork in the road. For example, early COVID, there were some very challenging decisions to be made. Explaining the difference between short-term and long-term consequences of certain decisions and forks in the road in financial terms, that has been really helpful. And I have one business I'm happy to like publicly share, there's a business called Blue Cloud Pediatric Ambulatory Surgical Centers. They're owned by Norwest Venture Partners. And during early COVID, we had a decision to make. We needed to decide, do we cut our costs and let go of a ton of workforce, which itself is often on the cusp of poverty? Or do we take the short or medium term hit, invest more in the company, keep people on board as long as possible, with the bet being that if we keep them on board, we're going to have profoundly more employee loyalty, profoundly better customer experience, clinical quality, and we'll be the fastest ones to ramp back up once all the stay-at-home orders get pulled back. That was one bet. The other bet was that, do we keep treating the kids for whom we do not have Medicaid coverage yet, for whom we are not in network with their payer yet? And we had, again, choice to make. We could treat these kids and take a pretty significant hit, or we could turn them away. They have, and these are mostly kids with complex care issues. They're oftentimes have cognitive impairment, so a general dentist can't treat them. You need anesthesia in order to do any kind of dental work. And so these are very high, kids are highly prone to complications from something as simple as a dental carie, which could quickly turn into an abscess and quickly just deteriorate into badness. And the company made the conscious decision, which I didn't have to do too much arm twisting. I just kind of laid out that my hypothesis is, if we make these short-term investments and perhaps not make cost reductions and look better from a EBITDA perspective, in the short term, it may hurt, but in the long term, it'll be beneficial. And what ended up happening is the company ended up, for the reasons I just described, exceeding its pre-COVID 2020 budget. It was more profitable than expected, despite COVID happening, because of all these reasons. Like, we were first to turn back on. We didn't have all the massive churn that everyone else had and had to rehire. Our employees loved the company because they were able to keep putting food on the table. So that was amazing. That bet panned out. And then by treating kids that, because some health plans had, let's just say, some bureaucratic challenges in getting us in network, we shared with some of and this is where, if any of you go the government route, post-entrepreneurship, this is where you can have an outsized impact as an investor, board member. I would go to my state Medicaid colleagues and I would explain to them, look, there's a business that I'm an investor in and I'm on the board of. They're treating your kids, even though that your MCOs are not paying for these kids' care. We're saving lives and keeping you out of the headlines. What can you do to help us make sure that we get paid? And boom, state Medicaid director after state Medicaid director applied a little pressure to remind the health plan leaders, like, hey, do you want to still be getting paid by the state? Turn on the faucet, we got paid. And all of a sudden, this is like an incredibly profitable business. The profit is driven based on improved clinical outcomes. And those short-term investments ended up having pretty remarkable long-term financial and societal impact. And to your original question, like, I didn't have to do a whole lot of arm twisting and say, hey, let's do the right thing socially.
Yeah.
These are people that want to make money. And I believe, and I think that data point and others show that there will be more money made in the long term by doing the right thing for patients.
Yeah. Making the smart financial move as well. That's awesome. Thanks, Andrey. Let's shift gears and get some questions from the audience. I see Beth Sanders from LifeBio. You have a question there. We've got a bunch that have been listed in the chat, so I ask you to be a little brief in your question, but please, Beth, if you can come off mute, tell us what you do and ask your question to Andrey.
Hi, Andrey. I'm Beth Sanders, and I have a company called LifeBio, but lately we've been doing loneliness interventions, so something called My Hello, which is phone-based and is working with Medicare, and we've worked with Medicaid too in the state of Ohio. But I guess I'm wondering, do you see a move to more reimbursement for mental health and behavioral health kinds of things coming? Is there going to be a shift into a more social model of care from what you know about the federal government as we go forward? Do they see that as impacting physical health?
Great questions, and great to meet you, Beth. In terms of mental health reimbursement going up, I think that is a solid maybe. I think we're out of what I think was a worst case scenario with this current administration, and I think the next administration, reimbursement can really only get better for mental health. To what extent it will get better, I don't know. I'm not optimistic we're going to have like wholesale system change, just because that would require both seats in Georgia flipping Democratic. I haven't looked at the most recent exit poll numbers. I don't think that's going to happen. And absent that happening, like we're not going to, at most, we're going to have marginal system change from a legislative perspective. In terms of a social model of care and looking at prevention and looking at upstream health determinants, I think we probably will continue to have, again, marginal improvements, but not wholesale change in that regard. Most of the US healthcare system is still predominantly, overwhelmingly fee-for-service based. And until we have a shift away from fee-for-service, prevention and upstream health determinants won't be profitable. I think most of what we see right now in the buzz will remain as buzz. And so I don't see like fundamental shifts across the entire system. I absolutely do anticipate a continued growth in integrated care models. I do see continued momentum in the direction of providers taking on increasing financial risk. And in those pockets, I do see early market opportunities for really interesting solutions to be sold into them. But the next 4 years, I don't think we're going to have any kind of fundamental shift in the healthcare system. With one exception, we may see some changes to Medicare drug pricing. I do not think we'll see any meaningful changes to drug pricing in the employer-based insurance space. And we already have an interesting regulatory change with Medicaid drug pricing, with value-based payment being allowable. And so the pharma space is going to be an interesting one to watch, especially with biologics. But outside of that, we're not going to have like system-wide change.
Thanks for the question, Beth. We've got a question from Jonathan Fite from Beyond Lucid Technologies. Jonathan, you want to come off mute?
How you doing, man?
I'm good, dude. How are you? Congratulations on.
Great to hear your voice.
Likewise. I was actually, dude, I got to tell you, I loved everything you just said. I was more just kind of plumbing the depths of your thoughts when you mentioned that being on the other side of government was not per se all that it was cracked up to be. And then you kind of left it there. I was hoping we might get some more dirt on what it was really like on the other side of the table. I will say personally, I love that you used the word profit like 4 times in a row, because I think it's a left out part of the conversation, right? I mean, the seeking not just to keep the lights on, but to make the lights brighter is something that Silicon Valley has forgotten. Funny money is a big problem right now, especially in our industry, right? I mean, you end up making bad decisions in some cases. There's going to be a talk next week, I believe, by a very well-known investor who has driven some companies into the ground using that calculation. So anyway, I was first of all, besides wanting to say hello, I thought you might give some more insight, not per se as Logan took it in the direction of what's Medicare and Medicaid like. I've worked in government too, as you know, in a different area, and I'd love to know what your experience was on the ground, getting the phone, what kind of phone calls you got, and just what perspective did you learn? Like you said, it was great, and then it wasn't. Tell us what happens when it wasn't.
Sure. Thanks for that, Jonathan. And sorry if I was just changing cameras here to plug my computer in.
You got like 4 inches taller, man.
There we go. Ta-da. The inflection point in my role in government was pretty unique in that we had a presidential transition to an unprecedented administration, and going from thinking that Hillary Clinton would be my boss's boss to going to Trump being my boss's boss was very difficult to swallow as a policymaker. And what was interesting is that I was brought in to make changes that on the surface, what Seema Verma was trying to espouse, which is more government efficiency, less red tape, more consumer centeredness, although she never used that specific language. But in reality, what she came in to do with the Medicaid program was not those things, right? She came in to gut the program, and she knew the program incredibly well. With Medicare, she didn't know and still doesn't really fully understand what the Medicare program is. And luckily, what that enabled career staff to do was to minimize her harm. And so I went from a position of being brought in to be the change agent, where my biggest difficulty was building trust with career staff and learning hard lessons, which in retrospect are kind of like table stakes, which is don't use jargon like Gemba walk or value stream mapping or service blueprint. Just use simple language that federal career staff are going to be able to understand. Those were my hardest problems before the administration flipped. When the administration flipped, my hardest problems were, how do I not break the law?
Wow.
But still make sure that the public understands that the White House is actively trying to kill poor people. And so fortunately, like the legal counsel in the Office of Ethics, became a great friend of mine, gave me kind of the guardrails of what was allowable and what was not allowable. And I'm proud to say I leaked a ton of information to my friends at Politico, Washington Post, New York Times. Like unfortunately, one silver lining of my terrible experience in government is that I have a very deep Rolodex of reporters because I kept leaking them information from the inside out. And as an entrepreneur, as a builder, as a creative, like you guys, being relegated to only play defense was an immense cognitive dissonance. And so doing that for a year was sucked. And that's what I meant by the inflection point.
No, I think, I would love, if you're cool, I'd love to hear some more of that offline from here. That's just very interesting. A lot of what, as I think, I deal with government a lot. I sell to emergency services, right? So a lot of it filters through government, and we don't necessarily feel it as acutely as you did. Were you considered a political position or?
Oh, I would have been fired so long ago. I was career, so they couldn't really fire me, which is a whole separate issue.
It's just really interesting that, you and I've been one of those folks who try to advocate the idea that the bureaucracy knows what it's doing, very much like you said, like they'll find a way to make things work. So to hear that it filtered down to you, but also how you pushed back on that is incredibly interesting. I see the link. Thanks for that. It's incredibly interesting. Just some of the challenges that I've faced dealing with vested interests, shall we say. So I appreciate that. And anyway, good to see you, man.
Thanks for the question, Jonathan. We've got a question from Dr. Alexandra Greenhill from Care Team. Dr. Greenhill would love to hear your question.
Hi, Andrey, and I'm happy to see you still in healthcare. So many people just give up and leave. And so thanks for the continuous push to new ideas. Now that you've been inside the building, building on some of the questions Jonathan was asking, do you think it's money, mindset, combination, or something else that's like the one thing that if we could change, if you had a magic wand or something that would make adoption of technologies easier? Because we all know that between everything available today, you could introduce like 20 new things that will make an immediate and measurable influence on all of the 4 ROIs. And so why is that not obvious to so many decision makers?
That's a great question. And I think the system is so complex and there's so many contributing factors to that what I would say is maybe I will pivot my answer and say the system is what it is, and it is incumbent upon us as the value discoverers to work within the very poorly designed system, acknowledge it for its poor design, try to seek out very differentiated, unique insight that is hard to access, and then act on that insight in a very big bet, moonshot kind of way. I think that's the best way I can take an optimistic spin and answer your question. And in that vein, one realization I had that I'll just reinforce here: don't start with Medicaid or Medicare. Start with where it's easier to sell. Employer-based, pharma, direct-to-consumer, back into the public payer space. Similarly, don't sell on a value basis. I was very proud of, in retrospect, it was a terrible mistake, trying to sell my software on a value basis, trying to have contracts set up such that I would only get paid if certain outcomes were met. That was a terrible idea in retrospect. Our system is a fee-for-service system. It only really understands fee-for-service widgets. And I would strongly advocate, if your solution or service is able to be reimbursed on a fee-for-service basis, find that damn CPT code, find that damn HCPCS code, and get reimbursed by submitting claims. Be boring, be very under the radar. Don't speak with the innovation people at a health plan or a health system. Just go after fee-for-service existing piping. And then once you have some really meaningful traction, then you can start to escalate. Like that's unfortunately how I found there's the most success early on, and getting around the poorly designed system that I think prompted your question.
Yeah, it feels like a matrix experience. There must be an architect somewhere and a key maker, but I can't find them.
There's since 1965, there have been many architects and many key makers, and that's the rub, right? There's so many of them. There's no single one, and even with with a Democrat-controlled Senate and Biden as president, maybe the system could change, but again, I don't think it will.
Thanks.
Thanks, Dr. Greenhill. We've got a question from Natalie Davis. Dr. Davis from Prevent Scripts. Natalie, want to come off mute?
Hey, Natalie.
Hey, Andrey, great to see you.
Hello.
For those of you Transformers that don't know, I believe Andrey and I are the only 2 pediatricians in the house.
Hey.
Great to see you. We served on a HIMSS mobile health board 4 years ago for about a year until it all fell apart and they started calling it something else. But anyway, Andrey, excited to see you. What are your suggestions on recruiting Medicaid and dual eligibles into clinical trials? We're working with University of Kentucky in our NIH nonprofit strategy. We're using Research Match, but I'd like to hear your thoughts on making sure we are having some Medicaid folks in those trials.
Really glad you're trying to do research with these populations. They're grossly underrepresented. I guess if trial recruitment is foundational to your business model, I would have a certain set of recommendations versus if trial recruitment was not central to it. Okay, outsource to a CRO.
It's just the way to fund the business. With
I would say outsource completely to a clinical research organization. Like it's an entire industry. They do it really well. They're expensive as hell, but I think if recruitment is not foundational to the unique value you're bringing to your financial customer, then I would spend your energy, your financial, your time, resources elsewhere, and just outsource this function. And I'm happy to recommend colleagues that run CROs
That sounds great. We could use some leads on that end. That'd be great, Andrey.
Okay, and Natalie, just to make sure, a follow up and don't offer an empty offer, would you be able to maybe email me and?
Yes, I will. What's
Okay.
your best email these days?
Sure,
We can
yeah.
get that. We can get that figured out off the
Okay,
call
perfect.
and share that. Thanks, Dr. Davis.
Thanks.
And we have time for one more question. Alan Gale from Amy Health. Why don't you hop off mute and explain what you do and ask your question?
Hi, Andrey. Our company, Amy Health, provides nutritional analysis and support for practitioners wanting to improve patients with basically food as medicine using evidence-based solutions. And my question is, for companies that are looking to go into this public Medicare and Medicaid space, does it make sense to potentially partner with someone who already has contracts in that space with some additional value-added technology or service that they don't offer themselves, but that works in concert with what they do perform?
Alan, I think that could be a great idea. I mean, distribution is everything, right? And if that partnership is, if you're mutually benefiting potentially from that kind of partnership, and they have a meaningful distribution, for sure. But then you get into the whole dynamics of opportunity cost, and is that the right partnership? And should you be using your scarce resources to try to optimize that partnership versus another partnership versus other organic means of customer acquisition? And I think that's where the real answer lies. I can share that I've had some really productive experiences with distribution partnerships. I've also had like really crappy ones. And I think there's parallels with recruiting team members. Like, you need to have folks that are culturally aligned. Ideally, their processes mirror yours. In other words, like you inevitably are a really agile organization just by virtue of being a startup. If you're partnering with some very large incumbent in a space and all they have is waterfall, that may be a real risk to benefiting from that distribution. And then you want to consider, like, is that partnership going to have tangent or indirect or orthogonal benefits or risks? For example, if partnering with that entity will box you out from partnering with another entity that could be equally or more valuable, or is partnering with that entity going to have brand risk or confusion? Or if you're going to be raising capital, is this an entity that has the capability to contribute capital, which is something I've done with a distribution partner, which was pretty productive. Lots of variables there, and I think that's probably just scratching the surface without having more context on the partnership opportunities you have available.
Thanks for the question, Alan. Because that was brief, I think we can squeeze in one more question. Lawrence from Avo MD, let me let you have the last word here, if you can hop off mute.
Oh, wow, that's a lot of pressure. Hey, Andrey, thanks so much for the time. Our business model and sales model has recently honed in on pediatrics.
Yeah, my man.
Yeah, although not the most fun segment to sell into, given low budgets, and especially now with COVID impacting already low budgets, it's just been tough. Would you have any recommendations just for how to approach selling like a piece of clinical software into the peds world, into children's hospitals? I know it's kind of a general question and it's a little tough, but yeah. Anything you've seen from your experience would be very helpful.
I think the main pediatric specific consideration is if you're selling into hospitals. Did I hear that right? Hospitals are a customer segment?
Yeah, hospitals and children's hospitals.
Yeah, I would say that the holy grail is ultimately being able to have the Children's Hospital Association somehow serve as a distribution channel or vouch for your offering. Alternatively, having like a top 10 children's hospital be an early anchor customer, because that will have a pretty meaningful signaling effect. And then there's always the tactic of, can you get one of those marquee top 10 children's hospitals or health systems as an investor, or have a real check signer, decision maker on an advisory board with equity. It's a bit convoluted because of conflicts of interest, but absolutely doable. And one of the tools in my toolkit whenever starting a new company or advising someone I may have invested in, that happens to be selling into health systems. I think without that, back to the metaphor of activation energy, the activation energy is just way too high to try to break in.
Thank you.
Lawrence, thanks for the question. Andrey, we're at the top of the hour. There are so many things we could continue to talk about. We didn't even get into more questions about your current role as an investor. There's just so much we could dig into. I hope we can maybe do this again sometime. The way that we conclude these fireside chats is by giving everybody on the call a chance to sort of reflect back to our guest, reflect back to Andrey, sort of a biggest insight, something that you're taking away from this time. Take a minute to think about that. And while you're doing that, I want to kick it over to our CEO, Stephen Krein, to maybe share his insight.
Hello, everybody. Happy New Year. And Andrey, it is awesome to see you, man. I am beyond, you and I were just chatting back and forth, how beyond thrilled we are that you've done this incredible tour of duty in healthcare, right? You're a doctor. Actually, most importantly, you're a husband, a father, an author, and a doctor. But then you became a health transformer and really got to experience everything that it means to be an entrepreneur. You became the chief medical officer of Medicaid. You're now an investor in one of the health transformers, City Block, no less. 3 years from now, where do you see yourself, and what has to happen for you to feel happy about your progress over the next 3 years?
Oh man, Steve, it's good to hear your voice. 3 years from now, I will probably be founding a tech-enabled PACE program, or a tech-enabled pediatric specialty, complex care health plan, or some other business, who knows? I suspect that I'll likely be getting my hands dirty again. But until then, I've got some commitments with portfolio company investments that need some hand-holding. So once I get a couple of the wins under my belt, and then get some of the big kid institutional investors to sniff out that they can make money in Medicaid, I think then I can say, okay, cool, I can get back in the saddle and get back to operating.
I love it. Well, look forward to welcoming you back. I know health transformer for life, but welcoming you back. That's great to see you and kick off 2021 with you and the community.
Absolutely. Thanks, man. Great to see you.
Awesome. So we've got time for one, maybe two biggest insights. Jonathan Fite, I see you raised your hand. Go ahead.
I did. I've gone through this journey alongside Andrey, and I got to tell you, man, it is actually, tacking on what Steve just said, it's really neat to hear someone be able to describe the life in the trenches. The number of times you said what I would have done, what I wish I'd done, but actually to reflect on that. I hope that's something that more people take the time. Again, I think I'm channeling Steve Krein a little bit. Hopefully he's smiling over there.
Aren't we all most of the time?
Yeah, but it's something. Look, we're so on the go, right? I mean, I'm still. I put in a petition to God for a few more hours a couple years ago. Still waiting to hear back, and so taking the time to ask what you did right, what you did wrong, what you did differently, and if we could do that along the way, then you could do it along the way, and move the ball a little bit one way or another while it's moving. So I love that you've taken the time to do that. I try to emulate that. I hope everybody sort of steps back outside themselves and says, am I going in the direction I thought I was going? And am I liking the direction that I am going? So cheers to you on that, man.
Thank you so much.
Thanks, Jonathan. If anybody else wants to share their biggest insight, you can raise your hand or drop your name in the chat. In the meantime, maybe our team can pop up the final slide, and we can let you know that we've got.
And Logan, really quickly, one thing I will offer. I protect a pretty decent amount of my time for trainees, clinical trainees in particular, who are considering a life of entrepreneurship. So if any of you all have folks on your team that are, you know, a med student or a resident or an MPH student or whatever along those domains that's looking for some clinical and entrepreneurial mentorship, I've got literally a bi-weekly research sprint where I protect time for that, and I always welcome the trainees so we don't get them accidentally stuck in academia for life.
That's awesome. Well, I speak for everyone on the call when we say thank you, Andrey, for taking time out of your busy schedule to share your experience, your knowledge. It was awesome. Startup Health invests in health transformers from around the world who are committed to achieving audacious health moonshots. If you want to learn how you can join this community of entrepreneurs, or if you want to connect with one of our 330 companies, go to startuphealth.com. Thanks for listening to Startup Health Now. We'll be back next week.